Good morning, everybody. It's my pleasure to moderate this session together with the group up here, the faculty and friends, Simon Eccleshaw, Florian Krakart, Antoinette Nelon, Peter O'Kane, and Christian Spalding. The session objectives are listed here. We first hear Christian tell us about the device itself, the solution SLR balloon, and the current status of the solution de novo trial. Then we'll look at two different cases and the usual format for this case in point session. The first one will be presented by Simon, making the complex simple, a DEB-only approach in a bifurcation lesion, 110 according to Medina. And then we'll have a discussion with Florian and Simon and all of us. Then case two, the wabi-sabi approach, a nice Japanese-inspired denomination that refers to the wisdom of natural simplicity and the finding of beauty in imperfection. That will be very nicely illustrated by Peter O'Kane. And again, we'll discuss the case, what was done, what could have been done together. And if I have time, I will try and summarize what we'll have discussed on one last slide. So, to lose the least time possible and to get moving.
Thanks, Phyllis, for that nice introduction. My conflicts of interest. So, why are we here? Drug-eluting stents were a revolution in the world of PCI, and the acute results are excellent. However, 2 to 3% of our patients still sustain adverse events per year, and this occurs every year without a plateau. So the results, the long-term results of drug-eluting stents are not perfect. And this is probably due to late stent thrombosis or late stent restenosis that is probably due to the presence of a metal scaffold. A leave nothing behind strategy has been tried previously with BVS. We also have DCB, first generation DCBs that are currently indicated and recognized as the treatment of in-stent restenosis, and there is promising data on the use of first generation DCBs in small vessels. And there is a second generation DCBs that are coming. This is the solution SLR, which is a sirolimus eluting balloon with sustained release. It has micro-reservoir technology. The sirolimus is embedded in micro-reservoirs that combine sirolimus and biodegradable polymer. And these micro-reservoirs, I will see later on, enable a sustained release of the drug that is effective for up to 90 days. And the device is a very deliverable balloon catheter that has cell-adherent technology, which contains and protects the microreservoirs during the insertion and the inflation, and also optimizes the microreservoirs to the tissue and to maximize the cellular uptake of sirolimus. So all this to show that it's important to obtain a 90-day sustained limus drug release to cover smooth muscle cell proliferation, which is obtained with this device and which is not obtained with all devices using limus drugs. And to come back to a few years ago, we all remember the importance of a sustained release, and therefore there is no class effect of these drug-coated balloons. These are the slides that were used and reused several years ago, showing the differences in release of the drugs between the different drug-eluting stents, the Endeavor, the Cypher, the Xience, and the Taxus, with striking clinical results difference in these drug-eluting stents due to differences in delivery of the drug. And once again, there is no class effect of the drug-coated balloons, and each of these new generation drug-coated balloons are in a clinical program to be able to assess the efficacy. The solution SLR has been tested in a coronary clinical program, and the solution de novo study, which is performed in Asia, in Europe, which is currently enrolling, is the largest of the trials that are done with the solution SLR balloon. This is the trial design of the study. A little over 3,000 patients will be randomized between two strategies. This is a strategy study comparing a sirolimus-eluting balloon strategy on the left that is done after lesion preparation. And once the lesion preparation is finished, the operator can decide if he believes that the preparation is sufficient, if there is no occlusive dissection, if there is no residual stenosis of less than 30%, the operator will then use the drug, the sirolimus-eluting balloon. In the DES strategy, it is a usual DES strategy for all target lesions. This is a clinically relevant study since we have broad inclusion criteria. The main exclusion criteria are STEMI, CTO, and left main disease. And we are expecting an up to 30% DS implantation in the SEB strategy arm, and up to now the actual rate after 1,200 patients is 21%. The design of this study has been published in the American Heart Journal, and there are a great number of participating sites, and I'd like to thank all the sites for the great work that they're doing in this trial. And up to date, we have 1,212 today patients that have been enrolled, which means we've enrolled approximately a little over 30% of the patients. What's interesting in this study is that the lesion location is clinical practice. And as you can see on this slide, we have a great number of patients that have proximal, mid LADs. This is not a small vessel study. This is an everyday practice study with 61% of the patients who have a vessel artery diameter of more than 3. And this is a rate of provisional STEMI, 21% per patient and 19% per lesion. And up to now, the recent DSMB meeting took place after the first 1,000 patients, and there was no protocol deviations of concern, and there was a very rare and small rate of adverse event and no significant alarming differences between the two groups. So in conclusion, although immediate and one-year outcomes with current DS are excellent, there is a 2 or 3% yearly adverse event rate with no plateau, probably due to the presence of a metal scaffold. Metal-free PCI with DC base may potentially reduce the rate of long-term adverse event. The solution SLR is a new generation DCB eluting sirolimus with a pharmacokinetic release profile comparable to the best-in-class DS. Solution de novo is the largest DCB randomized trial up to date, and a DCB strategy will be compared to a DE strategy in an all-comer population, and TVF will be assessed at 1 and 5 years. And this trial has the potential to impact clinical practice in a major way. Thank you for your attention.
Thank you very much, Christian. So the format of the session is that you're welcome to ask questions. If you want to do so, please use the mics. In the meantime, I have a question for you, Christian. Perhaps you'd like to tell us about how the use of this device has evolved since we've been enrolling, and you've been enrolling in your center for about a year's time. Has your approach changed? Has your tolerance or the use of the device evolved in any way?
Well, the answer is obviously yes. It's changed in two ways. Number one, because it's a very deliverable catheter, so that's a difference with the currently available drug-coated balloons. And the second thing is basically we started, like, in fact, almost all centers, by starting doing small little vessels, the obtuse marginal, the small right coronary arteries. And when we saw that the device was effective, we then improved and we continued, and we are currently doing, as I showed, LADs and double or triple vessel disease. It's also changed the way we prepare the lesions, which means we came back to several years before when we're doing coronary angioplasty with balloons, is that we have learned how to prepare balloons and how to obtain a good result after vessel preparation using non-compliant balloon, specialty balloons, rotablator, or shockwave.
Thank you. We have two questions. The gentleman in the back first. He was there first.
No. No.
I just give the micro for questions.
Oh, sorry, sir, then.
Okay. So, as you already mentioned, I was asking about the use of adjunctive devices or for vessel preparation, like using a cutting balloon or using a shockwave and rotablator. How commonly did you use it in this up till now? Because you studied 1,000 patients. Because I find, I have been using drug-eluting balloons quite commonly, like about 30 to 40 cases every month. And we use it about 75% or 80% patients, Wolverine, especially in a 3 millimeter balloon, or a rota plus Wolverine plus shockwave, whatever. So, and we try to get a stent-like result. So is it recommended in this trial also to go all the way to get a stent-like result before you put the stent?
Yes, exactly, which means that the decision, as I showed in the design, is that once you have the patient is in the drug-coated balloon group, you have to get a good result after your vessel preparation. A visual estimate of the stenosis is less than 30%, a non-occlusive dissection. We accept type B dissections, type A dissections, obviously, but the idea is to get an excellent result after vessel preparation. If you don't get an excellent result after vessel preparation, if you constantly have that recoil that keeps coming back or an occlusive dissection, you have the right to go on to stents, and the use of adjunctive devices encouraged. And what we've noticed in the trial is that the rate of these, the use of these devices has been increasing as we go on to this trial.
So finally, the other question is that how, like for long lesions, do you do a overlap of these balloons?
Yeah, the idea is to cover everything.
Cover everything with long balloons and overlapping balloons.
Yes.
And do you use
Slightly
FFR?
overlapping balloons.
FFR, how commonly it is being used in this for the
Oh my God.
final result?
Well, this is an excellent question for the steering committee. Yeah, well, FFR is used in some centers before and after, but as you know, there is absolutely no data on FFR and drug-coated balloons, so this is actually an area of investigation because we have the data.
Because in my practice, before I use a DCB or a DES, if I have a FFR above 0.9 after all this preparation, we go for a DCB.
Thank you very much. Okay, excellent first discussion. Okay, it's going to have to be short because we've got a lot of...
So, in drug-coated balloon world, most of them use tacrolimus, not sirolimus. Paclitaxel, yes.
Yeah.
So can you a little bit teach us about why, in this case, sirolimus and not tacrolimus? Because there are issues when you elute it with the balloon compared to stents.
Yeah, well, number one, with stents, I mean, the best results were obtained with the limus stents, and the problem with the drug-coated balloons was the deliverability, and the fact that it had to be sustained for 90 days, and that's what makes the complete difference here. You got micro reservoirs, you got a biodegradable polymer, so therefore the drug is released exactly like with the kinetics with a drug-eluting stent. So that's the aim, and that's the big difference with the previous drug-coated balloons that have been used in sirolimus.
Thanks, Christian. Okay, let's move on. And we now invite Simon Eccleshaw to come and present the first case, i.e. the case introduction, so that we can then discuss together with Florian what the options might be.
Thank you. Florian, you may have noticed that there's only one presentation of mine, not two. So you need to be awake and paying attention, because at some point we will stop and have a discussion. So thank you very much for the invitation to be here. Thank you everybody for coming. Hopefully we will promote some discussion with all of this. My name's Simon Eccleshaw. I work in the Norfolk and Norwich University Hospital in the UK, along with some of my friends and colleagues that are in the audience. I'm going to present a bifurcation angioplasty from the study. So, 69-year-old male with carcinoma of the prostate, a single episode of chest pain. He had transient anterolateral ST depression and a minimal troponin rise of 700. He was on aspirin and ticagrelor as per our usual standard protocols. This is the right coronary artery, which is not the problem. Here's some shots of the left system. And actually the first one, the central image, probably shows best that there's a very eccentric lesion in the proximal LAD leading into that LAD diagonal bifurcation. The other views, although you can see where the lesion is, you can't see it particularly well. So that's with a guide catheter in the working view, with the wire down, obviously. That's the bit we're interested in. Florian, you're up.
Yeah, thank you. So this is a Medina 110 bifurcation, and you do not want to, perhaps you do not want to touch the side branch. So you have two options: take a stand like a provisional T, or go on in a no stand procedure. And I know you a long time. I think probably you will go on with a drug-coated balloon strategy.
So would you wire the diagonal? Does it make a difference whether you're stenting or ballooning as to whether you're going to wire the diagonal?
Perhaps no touching the diagonal.
Sorry?
No touch.
Don't touch?
Don't touch it.
Whether it's a balloon or a stent?
Yeah.
So one wire?
One.
Okay.
But who would wire the diagonal? Who would definitely not?
I'll wire it only if it is a stent, not with the drug.
Oh, okay. No,
Not for.
Interesting.
this is a drug-eluting balloon session. So it's a bit of a giveaway, but yeah, you're right.
But it's a great point, isn't it? Because the point
But
is...
it's an important point, absolutely.
Yeah.
Very good point.
Yeah.
So who would wire the diagonal for a drug-eluting balloon approach? A few. And who would definitely not wire it? A few. And most of you don't care.
So this is our first balloon, which brings me on to the whole concept of lesion preparation. You're looking to balloon at 1-to-1 balloon-to-artery ratio by angiography, not by intravascular imaging. We generally start with non-compliant balloons. Depending on what we're treating, we have a low threshold for using cutting or scoring balloons in order to control the dissection and get good lumen gain. It's a slow, gentle inflation that we use. You want full balloon expansion and a slow deflation. So this was a 3.0 non-compliant at 6 atmospheres, 1-to-1. So that's the acute result. So we have a sort of checklist that we run through when we're doing our DCB angioplasty. So the first bit is related to what we've just done, the lesion preparation. Is it big enough? We've given a load of nitrates. Is there any recoil? No. Are your balloons deliverable? Yes. I can see Antoinette looking at me, and I think the answer here is going to be, you're cheating. You're using a view where you're not showing the call out, the lesion.
Because even on your first, you don't actually see the lesion in your setup shot.
Yeah, well, not particularly. So it's a very nice result then, isn't it? I've done a good job by hiding it from you. So the next bit is about safety. So does the patient have any chest pain? Do they have ECG changes? Do you have TIMI3 flow? Is there a vessel-threatening dissection with luminal compromise? And in particular, is the progressive compression of the lumen, which would suggest you've got an intramural hematoma? That looks okay to me. And then you need to be thinking about, can I deliver my balloon? You've just heard the solution is a remarkably deliverable sirolimus eluting balloon. And you want to go, again, 1-to-1, slightly longer than everything you've just treated.
Simon, just a question. You showed us one shot of an inflated balloon. Roughly, how many times would you have inflated and how many balloons in this particular lesion? Do you remember that?
One balloon.
One balloon. And just one inflation?
Yeah.
Okay, all right. Is that what you usually do, or would you usually do?
That's how we usually start.
Okay, so, but that's important, because what you're saying is you choose your first move and then you take it from there.
Yes, as we discuss on a regular basis. So if we hadn't got a good enough result, the first thing we'd do would be go back with the same balloon, bit high pressure, bit longer. If that doesn't work, we change to whichever speciality balloon you like. So we use a lot of Scoreflex and a lot of NSE alpha, again 1-to-1. And again, if it's not working, slightly high pressure, slightly longer, trying to get rid of, for example, the recoil that you may be seeing. And we discuss this every week, don't we now, on a Monday evening. So, different view. Again, have we done enough? Is it safe? Yes. So we're thinking about a balloon. So here's the setup shot with our sirolimus balloon going in. So it's 1-to-1, and you can see it's a little bit longer. So this is a 3020. 6 atmospheres, 30 seconds. The 6 atmospheres is that you're inflating the balloon to deliver the drug. You're not inflating the balloon to do more angioplasty. So we know we've done the lesion preparation bit, so everything after this is all about safety now, isn't it? So does the patient have any chest pain? Do they have ECG changes? Do they have TIMI3 flow? Is there a progressive luminal compromise, contrast hanging up in the vessel wall? Anything to suggest you've got a vessel-threatening dissection? And if the answer is no, and it looks good in both views, take the wire out. Who's happy with that result? Oh, seriously? The steering committee, okay.
How long did you wait before you pull the wire?
In a simple case like this, where it's all gone swimmingly well, we just take the wire out after we've taken a view or two, and we're happy that the checklist has been ticked, really. So,
thank you, Simon, for this case, and I think it's once again it's very important to the necessary to emphasize how important the lesion preparation and all the steps you showed is, and in an efficient lesion preparation before deciding go on with the DEB and do it only to deliver the drug with the drug-coated balloon. And this is open for discussion. Other questions?
I've got one more slide. You've stolen my last slide. Can I do my last slide? So I've just shown you a very simple bifurcation case. I was delighted it was randomised to the balloon, but then again, I'm always delighted when I'm ballooning, not stenting. Single vessel, single wire strategy. We did a non-compliant balloon that was the right size. It looked fine. So we used a sirolimus balloon, slightly bigger and longer. We used the safety checklist throughout. It's called very simple angioplasty with bifurcation. The acronym I now like is KISS-KISS, which is keep it simple, keep it stent-free, and you can apply that to all of your angioplasty. Thanks.
We have a question for the gentleman here, if we can give him a microphone.
Microphone is coming.
Yeah, very impressive. Thank you very much. Just one question: will you ever consider using the balloon twice, the drug-coated balloon, or just once?
I can't answer for every single balloon that's out there on the market, but the vast majority of them, it's a one-off delivery. Certainly, this one is a one-off delivery.
And how long do you? I mean, do you dilate the balloon for?
30 seconds.
30 seconds.
Yeah.
This is, I mean, it doesn't depend on the lesion. I mean, whether it is calcified or is it not calcified.
How long you deliver the drug for? No.
No, it's just 30 seconds. Yeah.
Yeah.
Okay. Thank you.
Other comments?
No. It's another one.
Yep.
Just there.
What about the second lesion? For me, it was just one very long lesion, not just so short that you. Excellent.
Yeah, we did go round in circles about was it just the proximal LAD, and you only really saw it.
I would use two drug-coated balloons, not just one.
Or you could have done one long balloon if you wanted to treat all the way through.
Okay, thank you.
Sir?
So regarding the duration of inflation, maybe the recommendation with this study is 30 seconds, but usually with the balloons which I've been using and also the solution, because we did the first in-man study with solution, we inflate it for 60 seconds is the minimum for us. And if the patient is tolerating, we even keep it for 90 seconds or 2 minutes. And it works quite well. So there is no problem in keeping it inflated for 90 seconds or 2 minutes. It works very well.
Yeah, and the recommendations are a minimum of 30, and 60 is recommended.
So I just say 30 to keep it simple. I'm keeping everything simple. If you say 30 to 60, then people start asking, are you doing 30 or 60?
So what do you think about other bifurcation stenosis, 111 or 1001?
Oh, okay. How long have you got? So the way we do bifurcation angioplasty now is if you think the side branch is involved, so if you're worried about side branch, you wire it like you would do in any angioplastic procedure. And then if you want to treat the side branch, it's because, to my mind, it's if the side branch in its own right is going to give the patient ischemia and angina. So I'm only treating it because that vessel needs treating. So if it's just the ostium of the side branch that's involved, and a bit like the EBC guidelines, first 5 millimetres of the side branch, then we don't pursue it. If it's longer than that, then we'd wire both. And the way we do lesion preparation then is as straightforward as I've just shown you, and I suspect we do it the same way. Thank you for the question. Main branch lesion preparation, side branch lesion preparation, do the checklist. If it all looks fine, side branch DCB, main branch DCB, stop. It's all sequential, no kissing, very simple.
Other comments? We have another minute or so. Okay, fine. Thank you very much, Simon.
Thank you.
And so we move on to the second case, which will be presented by Peter O'Kane. And he's got some really rather lovely videos to look at. So here we go.
Oh, don't give too much away, Philippe. Thank you. Just make sure it's loading. Thank you very much for the invitation. And while this is just loading up, I just want to thank Med Alliance for allowing us to be the UK lead centre for this study, which is really important. We're in front at the moment. Just about. We've got some tough competition. And I want to thank in the audience Jonathan Hinton, my fellow, and Hannah, our senior research nurse, who have been driving our programme locally. So I'm Peter O'Kane. I'm work in Bournemouth in the south coast of England. And for this presentation, as given the title, you can call me Dr. O'Kane. Because I've spent my whole life trying to be perfect, and perhaps we need to be more imperfect and just accept this beautiful Japanese technique. Oops, sorry. Can I just go back a slide? Just jump. So this case is an interesting case, and I want to thank the patients for taking part, because without the patients we couldn't do these clinical trials. It's not playing for some reason. Yeah, let me just...
You have to click on your picture.
Little arrow.
It's a video. Okay, I'll just leave it. So this is a 76-year-old patient who comes in with a coronary syndrome, as you'll see shortly. And he has a small troponin rise, and he comes to the cath lab. Now, in terms of the patient characteristics, he has a history of hypertension, diabetes, diverticular disease, and also ulcerative colitis. And his hemoglobin is stable, but he has bled in the past. Normal left ventricular function. We treat him medically, and we bring him back for an elective coronary angiogram. And as I say, the patients we're grateful for when they consent to go into the trial. So we kind of count him as a high bleeding risk patient based on some of those criteria. This is the angiographic setup shots, and you can see there is a lesion in the LAD in a proximal vessel, and it's over a sort of long length. So first of all, we're not sure if that's significant. So, it's not particularly severe coronary syndrome. So we do pressure wire. The IFR is 0.81. The FFR is 0.65. So reasonable mandate to treat, consider treatment. I'm a big imaging supporter, and that's what I use routinely, about 70% of cases. So we're going to do some HD IVUS, and we start with, you can see that very normal vessel distally, measure the EEL. It's about 3 millimeters. As we pull back, there's a little drop out with the IVUS, but as you pull back, you can see there's quite extensive plaque, which is over that sort of mid to proximal area. There's some calcification. We can't always tell thickness on IVUS. There isn't a huge amount of reverberation, whether you believe that or not, whether it tells you about thickness. But it's quite severe stenosis, and we can plot that out with IVUS. We can measure it, and we can get the MLA and understand, where we're likely to get the most benefit in terms of our treatment. And the proximal vessel, as often is the case, is much bigger. It's about 4 millimeters diameter. So that's, we've done angiogram, we've done the physiology, and we've done the intracoronary imaging. So we're set up now for the case. Now, in terms of what we're thinking and what's going on with me, I'm looking at this IVUS and I'm thinking, is there calcium? Well, there is some calcium, 270 degrees. As I said, you can't 100% determine thickness on this image, but in my mind, it's present. I have to be aware of it. The CSA is around 3.85. So in my mind, I'm thinking we're going to prepare the vessel. That's the first thing. We're going to use non-compliant balloons. We're going to score or cut. Are we going to take up front rotation atherectomy or IVL? And are we going to plan to randomize in this trial or treat outside the trial? So I'll hand over to Antoinette to give some comments.
Thanks, Peter. I mean, he's signed his consent, so I can see what way you're thinking here. You're very much on the solution idea. I mean, this is a typical kind of patient that we know we're going to end up with a very long stent, who's high bleeding risk and may pose problems later in terms of dual antiplatelet with a lot of stent over maybe 30, 40 millimeters there. So I think, to have this kind of patient in the trial is really important. We're going to have, more and more patients. It's a large vessel, proximal LAD, so it's, it's an important vessel, and it adds a lot of strength to the results that we're going to have in the trial. Number two, in terms of the lesion preparation, certainly more proximally, there is more extensive calcification, and it's almost approaching 360-degree calcification. So we need to do something with this artery beforehand. I think a stepwise approach is important, and I would definitely start with the balloon and see what the result looks like visually, and then decide whether I need to do more, because this can, going directly to lithotripsy or going directly to rotablator in this adds a lot of cost and a lot of time to the procedure. So I think to start like you tend to, Simon, take a balloon, see how you get on, and see if you need to do more than afterwards. So I would certainly randomise to the solution de novo trial, and I would start just with the balloon, even with the extensive calcification proximally.
Shall we see? Are there any other questions or suggestions from the room that burning at this stage? Doesn't seem to be there. Everybody wants. Sorry, Christian.
So you're going to do you still have the FFR wire in?
No.
Okay, so it would be. Would you routinely do the FFR after the procedure?
Yes.
Okay. And I have a question also from the audience. Is that do you routinely perform OCT IVUS in these cases?
So, I mean, yeah, as a big imaging user over the years, with stenting, and we've done scaffolding, we've done all sorts of things in the past, and I love imaging. It gives me a lot of information. I won't give too much away about what I think of it after this case, but I think we are doing a lot of the cases in the trial with imaging, which I think will be an interesting subset.
Please.
I'll put you out of your misery then. So what do we do? So I think Antoinette's comments are really well made, and I think you're absolutely right. The calcium burden here I didn't think was too severe. So our strategy is not to go up front with any form of device that's expensive. And we're going to just do as you suggested, really, when it loads. So videos, maybe stretching the system or something, I don't know.
Do we need help from the AV team?
I've clicked it a couple of times. See, I don't like PCs. I'm a Mac guy. Oh, here we go. I'm slightly worried this is not the final video that I actually put on the system yesterday, but anyway, we'll see. Right. So, how did I actually treat this case? Well, bearing in mind what Antoinette said, sorry, I go to conflicts of interest again, I'll stick with the rules. The preparation of the vessel I thought would be very reasonable with a non-compliant balloon, and of course this patient has consented, and we don't want to lose any patients if we think we can treat within the trial. So this patient does get randomized in the study. So we start with a 2.5 and then a 3.0 balloon, and the patient is randomized to DCB. Now, I guess initially when we got randomized DCB, we thought, oh, that's going to be tricky, but we're learning how to do this technique. Now, that was the angiographic image after ballooning, and I felt that this was not less than 30% stenosis, so I thought we hadn't finished at this point. But of course, I like to image during the case as well as at the start. So we're now performing some repeat IVUS. Again, we just go through the same setup as we would before. So we make some measurements distally. It's around the same diameter. Can get bigger, of course, over time when you dilate the lesion. And as that IVUS starts to pull back, you can start to appreciate there is some dissection that you see in there at sort of 5 o'clock. And there's this disruption in this plaque. The lumen generally here is bigger, so the balloons have had an effect. But then you come into this more proximal segment where there is still quite a significant residual stenosis, which fits with what I saw on the angiogram, and it's still, I think, more than 30%. And of course, often on the imaging, the stenosis will be more than 30%. So you have to take that with a pinch of salt. And then the proximal vessel is quite large, so there's quite a big size difference, which is interesting if you're considering a stent in these cases. So when we go back and focus on the area, I think where it's most suboptimal, where there is more recoil, again, we can get a very quantitative assessment, and the CSA is around 4.7. So it's a bit better than before, but not good enough. And I felt the next step would be to try and change the compliance of the lesion by using either a scoring or a cutting balloon. And in our centre, Angiosculpt is our go-to scoring balloon. It's very effective. Not super high pressure, just go in slowly at moderate pressure, and then take a 3.5 balloon, because that's what the imaging is telling me. And that's the angiographic appearance after that combination therapy. And again, to me, there's a bit of disruption there in the proximal vessel, but we're going to confirm that with some imaging. So here we are again with repeating the IVUS. None of this takes very long. It's, it might be an extra minute or two, but it's worth achieving that, I think, to get the information. And I think that it's fair to say there is a bit more disruption than there was before. So the scoring balloon has created perhaps some more space, but the downside is that there is some more disruption. But maybe that's necessary, and this is why I think this technique is quite useful to understand in the longer term, whether we have to be aggressive or not. Now there's the proximal dissection, which is visible on the IVUS, and that fits with what we're seeing on the angiogram. So I'm still quite happy. The patient's very stable. There's no ECG changes. We go back and again make sort of quantitative assessment, and I think the area now is much more suitable, just over 5. That's the angiographic image before we decide, and we have the option, of course, of crossover stenting, which is, in my head, is a real failure. So I don't want to ever go down that road if I can help it. So I'm going to continue with my randomization protocol, and we're going to use solution balloons. We use 2, and as suggested by some of the audience, they're overlapped gently, but it's important we get no geographical miss. We go up at nominal pressure for 60 seconds on both. They're very well tolerated. These patients have had these lesions for years. Quite often they can tolerate long balloons. We don't perform any further imaging because we don't want to disrupt the membrane on the balloon. So we just take our angiographic assessment. So that's sort of where we're finishing. Take this caudal view that I hadn't really taken much of in the case, and then I see this slightly less attractive image. And this will be an interesting point to discuss with particularly people who've done more DCB over the years. And I guess, for me, this was still very safe because there wasn't too much hold-up of contrast. There was TIMI3 flow in the vessel. The patient was entirely stable. And we had the benefit of repeating the pressure wire. So when I repeat the pressure wire, the physiology is really much more favourable. It's not like a stent, perhaps, but it's pretty good. And I'm pretty happy with the IVUS, the angiogram, and the patient and the pressure wire. So 6-month follow-up, patient's entirely asymptomatic, event-free, feels great. They stopped the clopidogrel at 6 months, which was, I thought, helpful. I'd say the scoring balloons are incredibly useful for lesion recoil. And in this case, I think the physiology and imaging was very helpful. And actually, you know, having been a massive user of imaging, I think if you're going to use it, if you're going to put a stent in, I think imaging is really important because you've got to know where you're landing your stent, which you cannot see on an angiogram particularly well. If you're using DCB, imaging maybe is less important. And I kind of can't believe I'm saying that, but it might be true. But I think if we can capture some of this information within this trial, it's the best opportunity we've ever had to be able to achieve this. And I look forward to continuing to enroll patients. Thank you very much.
Thank you very much, Peter. Super presentation. Lots of very good learning points. Questions, comments from the steering committee? Yep.
We have one comment that showed up on the chat, and the question was in the protocol is a 30% residual stenosis assessed by visual or by QCA in the cath lab, and the answer it's visual in the protocol. And obviously we have a core lab looking at all the procedures and calculating the residual stenosis after vessel preparation, but that's after the case.
Peter, do you think we need the imaging more for starting the procedures, or for recognizing the classifications and for deciding for a strategy?
I think that's a great question. I mean, we've had other cases in the trial where we've discovered calcium, and we've gone down the road of and they've been randomised to solution, and we've gone quite early with IVL as a treatment choice because it's low pressure, cracks the calcium, creates the lumen, and then I think, you know, you get great results, and you don't have to necessarily achieve what you might with a stent. And I think the imaging then is perhaps you don't have to go through so many systematic runs. You might just do a first run, get the information, and then use the angiogram to guide things. So I think algorithms are going to develop from this, and it's going to be really interesting.
I'd like just would any of you have felt uncomfortable with that type B dissection that Peter showed so elegantly at the end? Okay, but that's very interesting and honest, thank you. And we've noticed, looking at the angiograms of the first few hundred patients, that in fact the concept is evolving. As a group, the investigators in this solution de novo trial are becoming more and more tolerant with these dissections. And at first, people like myself, who have little experience with drug-eluting balloons, were really worried. But as you saw, the DSMB is not worried, and the events don't happen. And in fact, one case of abrupt closure within a couple of hours post-procedure we saw had a perfectly beautiful result without a dissection. So angioplasty induces dissection, and of course the tolerance level of what you have to treat or not treat is something that is evolving, I think. It's changing our views of coronary angioplasty. Further comments?
Yes, a practical question.
Sorry.
So we are going back home next week, and we have a high breathing risk patient. Should we consider treating him with red-coated balloon, or should we wait until we have some more evidence?
Yeah, that's a very good question, and it's exactly back to Christian's statement at the end of his conclusion slide, where he says this data has the potential to profoundly modify the way we treat patients. I think there's a lot of reason to think that it's perfectly safe, but exactly what the TLR rate will be compared to stents, this is why we are doing the trial, to find out. I think if the bleeding risk of your patient is very high, that would be a superb reason to do it now, because I think the trade-off is solidly in favor of shorter DAPT or even no DAPT and a balloon. That would be my take for May 2023.
And in the trial, for how long do you give clopidogrel?
Up to the investigators. We give no specific recommendations. I don't think we actually know what is ideal. But perhaps Simon, who's got a lot of experience, would you like to mention what your regimen is?
Thank you. So for all elective work, dual antiplatelet therapy for a month. For ACS, we're treating the patient rather than the lesion. So if you want to, up to a year. But you can stop it sooner from the point of view of safety of the lesion that you've just treated.
I kept it going for 6 months just on that case because of that dissection. I just thought go a little bit longer, but you're right, it could have stopped it earlier.
Yeah, just sorry, one question regarding that dissection. Won't you be more comfortable if you call the patient after 1 week or 2 weeks just to do a check angiography to see whether anything has gone wrong after that? Or are you comfortable to see him after 6 months or?
Well, so I think it's an interesting question. I mean, the benefit of doing cases like this within a clinical trial is that these endpoints are going to be captured so that we can't hide these cases. We will find out about them. Doing an angiogram in 1 week probably will look exactly the same because it's going to take time to heal. You're looking at least 4 to 6 weeks. I mean, we've seen it in our CTO work. We know when we do an investment procedure, we can trash the vessel. You often have to come back, 2 months later before you have another go. I think the clinical follow-up is more important. And I kept this patient in for 24 hours because it was probably treating me rather than the patient. But I think with modern dual antiplatelet therapy, I don't think we have to be that concerned. I think, things heal and they get better. And he stayed overnight and went home the next morning, which I normally do a day case and normally send him home the same day. So I just gave that extra caution, but I'm sure that was treating me.
So, sorry, could I just come in on that safety issue again? So if you're going to have a problem with a dissection at the end of a case, they will return to the lab within 24 hours. Almost virtually all of them are early. If you're then getting complications a bit later, it's usually a stent-related problem. So if they're going to come back to the lab because of your balloon angioplasty, generally it's within the first 24 hours. Very rare outside that.
We also have to accept the fact that it's been drilled into our minds that leaving a dissection after a procedure, which is always a stent, is bad, bad, bad. Edge dissection. This is not edge dissection. This is balloon-induced dissection. And therefore, we have to change the way we're looking at the angiograms and try and make ourselves understand that this is actually not a great deal. And Simon knew all along, and we're finding out. Sir.
Yeah. No, just to emphasize this fact, because this is the most frequent anxiety amongst people when they are using DCB. And let me tell you, in the last 2 years, we have used about more than 800 DCBs. And no acute occlusion. Absolutely zero. Various kind of dissections, sometimes even longer. But the use of, as Peter told, use of imaging and physiology is the most important thing, and good vessel preparation. We go up to, with the Wolverine or cutting balloon, go up to 18, 20 atmospheres, no anxiety. In that kind of LED lesions, if it is not responding, go ahead. Don't worry about, we have to get a good lumen to start with.
And of course, we have to remember that because we decide about bailout stenting after lesion preparation, when you look at trials where they randomize after lesion preparation, they've weeded out all the complicated cases, and it's no longer a strategy trial, it's a device trial, and the event rates will be very low. We include the patients, and we also keep him in the DEB group, even if he did belong to the 20% who then require a stent. Okay, I'll try and wrap up. How to optimize results of DB procedures based on these two cases and the interesting discussion we've had. I think we have to say again, yes, that our mindset needs to be adjusted. I've already alluded to that. Lesion preparation is critical. We've got to learn how to do that properly. It should usually be gradual, aiming for a final 1-to-1 balloon to reference diameter ratio. Specialty balloons are an important part of the devices that we want to use for proper lesion preparation. And as was also mentioned, rotational atherectomy in IVL can be useful in cases of heavy calcification. Then we got the issue of which dissection to touch or not. And we have found as a group that we could broadly classify dissection into two useful categories. The moderate dissections, type L, standing for leave it, usually do not require stenting. After full lesion preparation, if you have intractable recoil or severe dissection, type S, stent it, then you should stent it without prior use of a DEB. We encourage investigators to use the stent after lesion prep, not go on and use the solution just in case. It's extremely unlikely that it will look any better. And in fact, it shouldn't, because the SEB is there to deliver the drug, not to perform angioplasty, as Simon reminded us. I think based on this intermediate data, we can say that for a majority of de novo lesions, stentless PCI is feasible and appears safe. Our DSMB told us so. And yes, the trial, Solution de novo, is an ongoing experience. We are learning as we go. We now have more than 600 cases from 30-plus centers. The technique of the operators that we're monitoring by looking at selected angiograms is definitely improving, and confidence is growing. And on that, I hope we can all meet here again next year with a lot more experience, a lot more patience, and the same enthusiasm. Thank you very much.